Hello everyone and welcome. Today we're going to take a really deep dive into a drug that you've probably been hearing a lot about, Remimazolam. It's making some serious waves and for good reason. We're going to explore what makes it so different, where it fits in our clinical toolbox, and most importantly, how it might help us tackle some of those daily challenges with predictability and patient safety that we all face in our practice.
So here's our plan for this session. First, we'll set the stage and talk about why we even needed a new benzodiazepine. Then we'll get into the good stuff, Remimazolam's core advantages and its unique pharmacology. After that, we'll get really practical, putting it head-to-head with drugs we use every single day. We'll also cover how to use it in our more fragile patients, and finally, we'll look ahead at the questions that still need answering.
Okay, let's jump right in. To really understand the excitement around Remimazolam, we have to start by looking back at the tools we've been using for years. Understanding their limitations really helps us see the problem that Remimazolam was specifically designed to solve.
You know, this quote from Dr. Tischer just hits the nail on the head, doesn't it? It perfectly captures this love-hate relationship many of us have with benzodiazepines. On paper, they look fantastic. They provide great amnesia and anxiolysis, and they're generally pretty kind to our patients' hemodynamics. But in the real world, well, that's a different story. Their unpredictability, especially that slow and variable wake-up, can just wreak havoc on a busy OR schedule and lead to those PACU bottlenecks we all try so hard to avoid.
And this slide really breaks down the core of the issue. With traditional benzos like midazolam, you get a slower, sometimes unreliable onset, but the real headache is the context-sensitive half-life. We've all been there, right? You stop the infusion after a long case and you're left wondering, when is this patient actually going to wake up? That variability is a killer for efficiency. And on top of all that, we have the ever-present concerns about postoperative delirium and cognitive dysfunction, especially in our older patients. It was clear there was a huge gap, a need for a drug with all the benefits of a benzodiazepine, but without these major drawbacks.
So, how does Remimazolam step in to solve this puzzle? Well, it wasn't just a happy accident. This drug was engineered, literally, designed from the ground up to fill that clinical gap. Think of it as a designer drug for anesthesiologists. The name itself is a hint. It combines the therapeutic profile of midazolam with the ultra-short-acting metabolism of remifentanil. This is a targeted evolution of the benzodiazepine class.
Now, at its core, the mechanism here is classic benzo stuff, nothing that will surprise you. It's a positive allosteric modulator of the GABA-A receptor. It basically finds that receptor, which is our brain's main off switch, and makes it more sensitive to the natural neurotransmitter GABA. This leads to all the effects we want, sedation, anxiolysis, and so on. But here's the key. The real magic of Remimazolam isn't in what it does at the receptor, but in how quickly and predictably our body gets rid of it afterwards.
And this right here, this slide explains the game changer. It's all about the metabolism. Unlike Propofol or Midazolam, which have to travel down that often congested cytochrome P450 highway in the liver, Remimazolam takes a different route. It's rapidly broken down by non-specific tissue esterases that are found all over the body. This process is fast, efficient, and, critically, it produces an inactive metabolite. The clinical implications of this are just profound. It means the drug's performance is predictable and consistent. It's not heavily dependent on a patient's liver function or what other drugs they might be taking. That gives us a level of reliability we just haven't had before.
So these unique features translate directly into some really exciting clinical applications. In the US, its approval is for short procedural sedations, but internationally it's used much more broadly for general anesthesia. But where this drug really starts to shine is in our sickest patients, the ones with cardiovascular instability, where every drop in blood pressure counts. Its profile also makes it a fantastic candidate for neuroanesthesia. Think about an awake craniotomy. You need your patient calm and still, but also cooperative and breathing spontaneously. That's a tough balancing act, and Remimazolam's profile is almost perfectly suited for it.
All right, let's get into the weeds a little bit and look at the numbers behind the magic. Understanding the pharmacology, the science behind its speed and predictability, is absolutely key to using it effectively and confidently in your practice.
This timeline just lays it out so clearly. You push the bolus, and boom! Within a minute, your patient is sedated. You reach peak plasma concentration in about 1 to 2 minutes, and the peak clinical effect follows right behind. But the most impressive part is at the end of the timeline. Full recovery in about 11 to 14 minutes. This isn't just fast, it's consistently fast. Think about what that kind of predictability means for patient flow, for PACU efficiency, and for your own peace of mind.
Now, this table is so important for understanding why Remimazolam works the way it does. You have this combination of very high clearance, it's cleared about 3 times faster than midazolam, and a small volume of distribution. In pharmacokinetics, that combination is pretty much the holy grail. The small volume of distribution means the drug doesn't go hiding in the body's fatty tissues, and the high clearance means it's whisked out of the system incredibly quickly. Together, these two factors are what give us that beautifully short and, most importantly, stable context-sensitive halftime.
And this is the number I really want you to remember, 7 to 8 minutes. That's the context-sensitive halftime after a 2-hour infusion. That is just remarkable. It means that whether your case is 30 minutes or 3 hours, you can expect the same rapid, predictable emergence. This is what fundamentally separates Remimazolam from other benzodiazepines and even from Propofol in those longer cases. It's a true game changer.
Okay, so the science is really compelling, but let's bring this back to the real world. How does Remimazolam actually perform in the ring against the heavyweights we use every single day? Let's look at the head-to-head comparisons.
The main event for many of us is Remimazolam versus Propofol, and the data here are very clear. First, and perhaps most importantly, Remimazolam offers far superior hemodynamic stability. We've all seen that Propofol-induced hypotension, especially in our fragile patients. Remimazolam significantly reduces that risk. It also causes less respiratory depression. On a practical note, because it's water-soluble, there's no injection pain, no more Propofol burn. And of course, there's the ultimate safety net. You have a specific reversal agent in flammazenil, a get-out-of-jail-free card that simply doesn't exist for Propofol.
And this slide puts hard numbers to those claims. This isn't just anecdotal, this is meta-analysis data. Look at the risk ratio for hypotension. 0.43. That means you cut the risk of hypotension by more than half compared to Propofol. And you see similar, massive risk reductions across the board for bradycardia, respiratory depression, and hypoxemia. These are not small differences. For that sick patient with an EF of 25%, this is a major leap forward in safety.
Now, when you compare Remimazolam to its parent compound Midazolam, it's like comparing a new smartphone to an old flip phone. They do the same basic job, but one is just worlds better in every performance metric. The onset is faster, the recovery is faster and vastly more predictable, and that context-sensitive halftime stays short and stable, unlike Midazolam's, which just keeps climbing the longer your infusion runs. It all comes back to that brilliant, organ-independent estrase metabolism.
Okay, so the theory is great. Let's talk practice. Let's bring this into the OR and the procedure suite. How do we actually use this drug safely and effectively, especially when we're caring for our most vulnerable patients?
Think of this table as your starting guide. For procedural sedation, a common approach is a 2.5 to 5 milligram bolus, followed by smaller top-ups as needed. The key here, and it's a big one, is to be more conservative with your initial dose in sicker ASA 3 and 4 patients. For general anesthesia, you're typically looking at a bolus of 0.2 to 0.4 milligrams per kilogram, followed by an infusion. But remember, these are just starting points. The most important rule is always titrate, titrate, titrate. Watch your patient, use your monitors, and adjust your dose to the clinical effect you're seeing.
This is another slide that's just critical for day-to-day practice. For our elderly patients, you'll likely want to reduce the dose due to their increased sensitivity. For patients with severe renal disease, the news is remarkably good. No dose adjustment is required. The most important group to be cautious with is patients with severe hepatic impairment, a Child-Pugh score of 10 or higher. In these patients, clearance is reduced by about 38%, so you need to start with a lower dose and titrate very carefully. For other populations, like obese or pediatric patients, the data is still emerging, so the principle remains the same. Start low, go slow, and titrate to effect.
And finally, a quick safety checklist. The most significant drug interaction, not surprisingly, is with opioids. They work synergistically to cause respiratory depression, so if you're using them together, you'll want to reduce your doses of both. Here's a really crucial practical tip. Do not mix Remimazolam with lactated ringers or aceted ringers. It can precipitate in your IV line, so always check your lines and flush well. And lastly, there is one absolute contraindication, a history of a severe hypersensitivity reaction to dextran 40, which is an excipient used in the drug's formulation.
So Remimazolam sounds pretty fantastic. But as good scientists and clinicians, we always have to ask, what don't we know yet? A responsible adoption of any new technology means understanding its limits and knowing what questions still need to be answered.
There are still some important questions on the table. A big one is long-term neurocognition. Does this drug's cleaner pharmacokinetic profile translate to better long-term brain outcomes for our patients? We need more data. We also need to formally establish its safety and efficacy in populations like pediatrics and during very high-risk surgeries like cardiac cases. And of course, there's the big question that our hospital administrators are asking: is it cost-effective? We need to prove that the higher upfront cost is offset by gains in efficiency, like faster recovery and better OR throughput.
So, to bring it all home, what's the big takeaway? The Remimazolam proposition really rests on these 4 pillars. First, it offers unparalleled predictability and control. Second, it has an enhanced safety profile, especially regarding hemodynamics and respiration. Third, it has a clear advantage in our sickest, highest-risk patients. And finally, it comes with that ultimate safety net, a specific, effective, and rapidly acting reversal agent.
This really leaves us with a forward-looking question to ponder. It's not just about whether we should swap one drug in our cart for another. The bigger question is, how might this new tool, with its unique profile, allow us to fundamentally rethink our anesthetic plans and provide even safer care for our most complex and fragile patients? It's something to think about as we move forward. Thank you for your time today.